Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. Let's talk about the gastrointestinal system. So things that we're going to monitor for within the gastrointestinal system. So the first one is a retroperitoneal hemorrhage. So signs and symptoms, we're going to see hypotension, back pain, something called Turner's sign. So this is a gray-blue discoloration of the flank seen in acute hemorrhagic pancreatitis. We could see a hematoma and we'll see decreased distal pulses. We also want to monitor for a bowel perforation. So signs and symptoms, abdominal guarding, pain, distension, fever. They'll be pale, tachycardia, tachypnea. Dysphagia. This is a patient is at an increased risk of aspiration pneumonia because they have difficulty swallowing. Nursing interventions have evaluated by speech therapy. They may need thickened liquids, soft meals, put the head of the bed in high Fowler's 30 minutes post-meal, and have them swallow twice before taking another bite. As far as what we can see with stool and bowel movement, so we can have constipation. This will be small, dry, hard stool. We can have biliary obstruction. So the stool will be light gray or clay color. For ulcerative colitis, they'll have mucus in the stool. Pancreatitis, it will be a greasy, fatty, foamy stool. If they have an upper GI bleed, we'll see black tarry stool. A lower GI bleed will be bright red, and hemorrhoids will be blood on the surface of the stool. When we talk about constipation, our nursing interventions are going to be to ambulate the patient because this will increase peristalsis, put them on a high fiber diet, make sure they're drinking 2 to 3 liters of water a day, and have them on a bowel regimen. Let's talk about some different medical diagnoses you'll see within the gastrointestinal system. So the first one is GERD. This is better known as heartburn. They'll have heartburn, epigastric pain, dyspepsia, nausea and vomiting, pain swallowing. Our nursing interventions can include having them avoid irritants like coffee, chocolate, fried foods, carbonated drinks, and alcohol. And they can also be medicated with things like antacids, H2 receptor antagonists, or PPIs. Inflammatory bowel disease. So this is not to be confused. So this is not irritable bowel syndrome, IBS. So this is not that, okay? These are two different things. IBS is like a food intolerance, more that situation. Inflammatory bowel disease is an autoimmune condition. So the body is fighting the intestinal tract. We have 2 types, ulcerative colitis and we have Crohn's. So ulcerative colitis is the chronic inflammation leading to poor absorption of nutrients. It begins in the rectum and spreads upward. The colon becomes edematous and has these bleeding lesions form on the mucous membranes. So scar tissue causes diminished absorption of nutrients. There'll be periods of exacerbations and remissions like any real autoimmune disease. So symptoms, anorexia, malaise, frequent bloody diarrhea and mucus, abdominal pain, fever, fatigue, weight loss. The thing to know for ulcerative colitis is this is only affecting the very first lining of the mucous membrane of the intestine. So it's only affecting that outside lining, and they get ulcers on this lining. And that's what's creating the blood in the mucus. So our nursing interventions in an acute phase, they may be NPO, need an IV, or parenteral nutrition. We restrict their activity to reduce intestinal activity. We monitor stool color, consistency, and for any signs of blood, monitor for hemorrhaging, perforation, or peritonitis. They may be on a low fiber diet during an exacerbation. They want to avoid alcohol, caffeine, raw fruits, raw vegetables, whole wheat, and milk. These patients may need surgery to create a stoma. The stoma should be pink. If it's purple or black in color, this indicates compromised circulation. When it comes to Crohn's, this inflammation can occur anywhere in the GI tract. For Crohn's, how we talked about with ulcerative colitis is just the outside lining. Crohn's can go all the way through. These ulcerations, it can create fistulas because it can be the entire membrane of the intestines. We can see leads to thickening and scarring, a narrowed lumen, fistulas, ulcerations, and abscess. Again, remissions and exacerbations. We can see things like fever, cramping after meals, weight loss, dehydration, abdominal distension, anorexia, nausea, vomiting, weight loss, anemia. And our nursing interventions are during an acute episode. It's the same as ulcerative colitis. And again, surgery may be necessary, but is avoided as long as possible because recurrence of the disease in the same region is likely to occur. Let's talk about diverticulitis. So this is an outpouching or herniation of the intestinal mucosa. It usually is discovered during a colonoscopy. Usually these people are asymptomatic and no treatment is needed. Diverticulitis, which is an inflammation of the diverticula, which can form an abscess. Signs and symptoms are left lower quadrant pain that increases with coughing, lifting, or straining. They may have an elevated temperature, nausea, or vomiting. They may have abdominal distension. They may have a palpable, tender rectal mass, and there may be blood in stool. Our nursing interventions are to provide bed rest during an acute phase, NPO status or clear liquids, monitor for perforation or hemorrhage, increase fluids to 2,500 to 3,000 milliliters a day, treat with antibiotics and a clear liquid diet, and introduce a fiber-containing diet gradually when the inflammation resolves. So then let's talk about peptic ulcer disease. So this is ulcerations in the mucosal wall. This is ulcerations in the mucosal wall of the stomach, pylorus, duodenum, or esophagus due to gastric secretions. Patients will complain of a gnawing, sharp pain in the left lower mid epigastric region that occurs 30 to 60 minutes after a meal. Food indigestion accumulates and causes the pain. Hematemesis is a common than melena, so coughing up blood is more common than passing blood or dark colored blood in the stool. Our nursing interventions are to monitor for signs of bleeding. If they're bleeding, we want to get vital signs, check for signs of dehydration, shock, sepsis, and respiratory insufficiency. We want to maintain NPO and administer IV fluids, monitor H&H, administer a blood transfusion and medication as prescribed if needed. That would be if they're bleeding a lot. Administer small bland feedings during the active phase, administer antacids, anticholinergics, mucosal barrier protectants, and prostaglandins as prescribed, and educate the client on avoiding caffeine, chocolate, alcohol, NSAIDs, and aspirin. So those are our interventions if it's in the gastric area. Now, if it's in the duodenal area, we're going to see things like burning pain that occurs in the mid-epigastric area 1.5 to 3 hours after a meal that often awakes the client at night. They may have dark colored stool from blood passing in the stool, more so than coughing up blood, and pain is often relieved by the ingestion of food. Nursing interventions monitor vital signs, teach them to eat small meals frequently with a bland diet, encourage smoking cessation, and administer H2 receptor antagonists or PPI. Now let's talk about gastritis. So there's two types of gastritis. We have acute gastritis and chronic gastritis. So acute gastritis is a stomach inflammation due to contaminated food. This is going to have abdominal discomfort, anorexia, nausea and vomiting, a headache, hiccuping, and reflux. Our nursing interventions are food and fluid that are withheld till symptoms subside. We can give them ice chips, clear fluids, and then solid food. When it's chronic gastritis, this is caused by ulcers, H. pylori, autoimmune, diet, medications, alcohol, smoking, or acid reflux. Symptoms include anorexia, nausea, vomiting, or belching, heartburn after eating, a sour taste in their mouth. They may have a B12 deficiency. And our nursing interventions are going to be NPO, monitor signs for hemorrhagic gastritis. So that would be hematemesis, tachycardia, hypotension, and avoid irritating foods and fluids. Then we have something called dumping syndrome. So this is a rapid emptying of gastric contents into the small intestines after gastric resection. So this is after a gastric bypass. Signs and symptoms. So it occurs 30 minutes after eating. We'll see nausea, vomiting, diarrhea, abdominal fullness and cramps, tachycardia, weakness, dizziness, and boregic sounds, which are loud, gurgling abdominal. So our nursing interventions, we want to teach patients that have had a gastric bypass to eat small meals and avoid fluids while eating. We can teach them to lie down after meals, avoid sugar, salt, and milk, and eat high protein, high fat, and low carb meals. Now let's talk about cholecystitis. So this is an inflammation of the gallbladder that may be acute or chronic. If it is acute, it's associated with gallstones, and if it's chronic, it's due to the inefficient bile emptying and inflammation of the gallbladder. Signs and symptoms we'll see are nausea, vomiting, flatulence, epigastric pain radiating to the right shoulder or scapula, which occurs 2 to 4 hours after fatty foods or a large meal. We can feel a mass in the upper right quadrant. They'll have right upper quadrant pain, guarding, and rebound tenderness. We can look for something called Murphy's sign. This is where they feel like they can't take a breath because of the pain when fingers are pressed on the hepatic margin. We can see tachycardia, elevated temperature, and dehydration. Now let's talk about obstruction in the gallbladder. So signs and symptoms are jaundice, dark orange and foamy urine, stratea and clay-colored stool, and pruritus. Our nursing interventions are NPO, NG decompression. For patients with chronic colitis, instruct them to eat small, low-fat meals. So now let's talk about cirrhosis. So this is destruction of hepatocytes, which leads to scar tissue formation. This is in the liver. Chronic causes are hepatitis C, alcoholism, non-fatty liver disease, and non-alcoholic steatohepatitis. Complications are portal hypertension due to flow obstruction, ascites due to congestive hepatic capillaries that lead to plasma leakage, coagulation deficits, coagulation defects, bleeding, esophageal varices, jaundice. The liver cannot metabolize bilirubin, portal systemic encephalopathy, and hepatorenal syndrome. So signs and symptoms, we can see a change in the level of consciousness due to failure of the liver to get rid of ammonia in the system. We can see ecchymosis, petechiae, and pulmonary erythema, leukopenia, dysrhythmias, fatigue, anemia, ascites, abdominal pain, dysphagia, and many others, because most systems of the body are affected. And our nursing interventions are going to include elevating the head of the bed if they're having shortness of breath, provide vitamin supplements, restrict sodium and fluid intake, enteral and parenteral feeds, diuretic medications for ascites, weigh patients daily, monitor the level of consciousness, monitor for asterix. This is a coarse tremor characterized by non-rhythmic extensions and flexions in the wrists and fingers. We want to administer lactulose. This is a medication which facilitates the excretion of ammonia. Administer antibiotics. This inhibits the synthesis in bacteria and decreases ammonia production. Avoid opioids and sedatives. Teach the importance of alcohol abstinence. Monitor ammonium levels. And to help with pruritus, cut nails short, calamine lotion, cool wet cloths, avoid hot showers, and cholecystitis. Another diagnosis we may see is esophageal varices. So these are dilated veins in the submucosa of the esophagus. It's caused by portal hypertension associated with liver cirrhosis. And if they start bleeding, this is a medical emergency. Signs and symptoms are hematemesis, so coughing up blood, dark blood in the stool, melena, ascites, jaundice, hepatomegaly and splenomegaly, dilated abdominal veins, and signs of shock. We're going to monitor for signs of rupture because this is life-threatening. Monitor vital signs, watch for orthostatic hypotension, monitor lung sounds, and note any presence of respiratory distress. Elevate the head of the bed, administer O2 to prevent hypoxia, monitor level of consciousness. They'll be on NPO status, receiving fluids with IVs, monitor H&H, administer clotting factor and blood transfusion as prescribed, insert an NG tube or balloon tamponade as prescribed, and instruct the client to avoid activities that will promote vasovagal response. So things like bearing down or straining during a bowel movement, we want to instruct them not to do that. Then we have appendicitis. So this is an inflammation of the appendix, and rupture can occur quickly, which leads to peritonitis and sepsis. So our signs and symptoms, so pain in the perineal area radiating to the right lower quadrant, pain near the belly button that radiates to the right lower quadrant. This is key. If you see that on an exam, that's appendicitis. Abdominal pain at McBurney's point, so this is another key thing to know. Abdominal rigidity, fever, nausea, vomiting, anorexia, abdominal guarding. Our interventions are going to be NPO, IV fluids to prevent dehydration. Do not palpate or apply heat to the abdomen. This increases the risk of rupture and peritonitis. Apply ice packs. And let's talk about hepatitis. So our goal is to increase blood supply, rest the inflamed liver, and reduce demands. So there's a few different stages in hepatitis. So we have the pre-ictic stage. This is the first stage of hepatitis. We'll see fever, malaise, fatigue, anorexia, pain, headache, and muscle aches. Then we have the icteric stage, and this is the second stage of hepatitis. We'll see signs and symptoms of jaundice, pruritus, elevated bilirubin, dark urine, clay-colored stool. And the post-icteric stage, they're starting to get better. So jaundice will decrease, urine and stool color return to normal, energy increases, pain subsides, and minimal GI symptoms. So now let's talk about types of hepatitis. So the first one is hepatitis A. This is spread through a fecal oral route, and it's a person-to-person contact with contaminated food or water and poorly washed utensils. Our incubation period is 2 to 6 weeks. Infection is another 2 to 3 weeks before and then 1 week after jaundice. And hepatitis A viral antibodies are found in the blood at an increased level will indicate infection. So our complications are fulminant hepatitis. This is a severe, acute, and often fatal hepatitis. Nursing interventions, we want good hand washing. When handling stool, we just being careful, always using the precautions, treating municipal water supplies, hepatitis A vaccine. There is an immunoglobulin for travel or exposure. Then we have hepatitis B. This is spread through blood or bodily fluids. Increased risk for IV drug users, healthcare workers, those who work in prisons. Common in all age groups. Incubation period is 6 to 24 weeks. A hepatitis B surface antigen will disappear in 6 weeks. If not, then the patient is a carrier. And again, those complications are the fulminant hepatitis, chronic liver disease, cirrhosis, primary hepatocellular carcinoma. Our nursing interventions include hand hygiene, screening blood donors, testing pregnant women using our needle precautions, avoid sexual contact with hepatitis B positive individuals, hepatitis B vaccine, and a Hep B immunoglobulin for those who are exposed. Then we have hepatitis C. This is also spread through blood or bodily fluids. Increased risk for IV drug users, healthcare workers, those in prisons. Our incubation period is 5 to 10 weeks. Hepatitis C viral antibody will be found in the blood. And our complications are chronic liver disease, cirrhosis, and primary hepatocellular carcinoma. And again, nursing intervention, strict hand hygiene, needle precautions, screening blood. So now hepatitis D is interesting because it only occurs with the presence of hepatitis B. It's common in Mediterranean, Middle Eastern areas, has an intubation period of 7 to 8 weeks, and will see a hepatitis D antigen found in the blood. Our complications again are that fulminant hepatitis and chronic liver disease, and nursing interventions are prevention, which includes the hepatitis B vaccine, since hepatitis D also needs to coexist with hepatitis B. And then hepatitis E is a fecal and waterborne virus. Intubation period is 9 weeks. We'll see IgM and IgG antibodies to the hepatitis E viral found in the blood. Complications, there's a high mortality rate in pregnant women and fetal demise. And nursing interventions are strict hand hygiene and treating water supplies. Let's talk about home care instructions for those with hepatitis. So we want to teach patients good hand washing. Don't share bathrooms unless the client strictly adheres to personal hygiene. And this again is for hepatitis. This would be hepatitis A and hepatitis E. So the ones that are spread through fecal oral route. Washcloths, towels, drinking and eating utensils, toothbrushes, and razors must only be used by the patient. The patient may not prepare food for other family members. They should, for all types of hepatitis, patients should avoid alcohol and over-the-counter medications, particularly Tylenol and sedatives because they're hepatotoxic. The patient should increase activity gradually to prevent fatigue. The patient should consume small, frequent meals consisting of high carbs, low-fat foods. The patient cannot donate blood. Close personal contact such as kissing and sexual activity should be discouraged with hepatitis B until surface antigen tests are negative. And the client should carry a medical alert card noting the date of the hepatitis onset. All right, let's talk about pancreatitis. So this is when pancreatic enzymes escape into surrounding tissue. There are 2 types, acute, which occurs suddenly as one attack, or recurrent with resolutions. Signs and symptoms include abdominal pain, mid-gastric or upper, left quadrant radiating to the back. So that's important to know. The locations of the pain can really tell us what it is. So it's important to remember the locations of pain with certain diagnoses. Pain aggravated by fatty meal, alcohol, or lying in a recumbent position. This is also important, the fatty meal piece. You may be asked about that. Abdominal tenderness, weight loss, absent bowel sounds. This is also important to know. Something called Cullen's sign, which is discoloration of the abdominal and periumbilical area, and Turner's sign, which is blue discoloration of the flanks. Our nursing interventions include withholding food or fluid during an acute period and maintain IV fluids, administer parenteral nutrition for severe nutritional depletion, and an NG tube may be inserted if they are vomiting, have a paralytic ileus, or a biliary obstruction. Then we have chronic. This is a continual inflammation and destruction of the pancreas with scar tissue. Signs and symptoms are abdominal pain and tenderness, left upper quadrant mass. They may have stertoria and foul-smelling stools that may increase in volume. We may see weight loss, muscle wasting, and jaundice. And we may see signs and symptoms of diabetes. So our nursing interventions, we want to limit fat and protein intake, avoid heavy metals, and avoid alcohol, administer pancreatic enzymes. We also want to look at, this is the lab, ALT and AST. These enzymes release when hepatic cells are injured. So 2 other diagnoses we may see related to the gastrointestinal system are a small bowel obstruction or a large bowel obstruction. So for a small bowel obstruction, we're seeing signs and symptoms of rapid onset nausea and vomiting, intermittent abdominal pain, and abdominal distension. For a large bowel obstruction, this is going to have a gradual onset, cramping and abdominal pain, abdominal distension, and complete constipation and no passing of gas. Nursing interventions for both of these are NPO, NG tube insertion, IV fluids, and managing pain. And the last diagnosis we're going to discuss is a paralytic ileus. This is a temporary halting of peristalsis for 24 to 48 hours after a bowel procedure. and no bowel sounds will be auscultated. All right, so let's talk about different bowel procedures. So first we have gastric surgery, and our nursing interventions for this include following the gastric surgery. Do not irrigate or remove the NG tube unless specifically prescribed because of the risk for distribution of gastric sutures. Monitor closely to ensure proper function of an NG tube to prevent strain on the anatomical site, and contact the healthcare provider if the tube is not functioning properly. We want to monitor respiratory complications that could be caused by pain at the insertion site. We want to encourage coughing and deep breathing, encourage ambulation, instruct the client about splinting the abdomen to prevent discomfort during coughing, administer antiemetics, administer analgesics, maintain NPO status, and the NG tube suction as prescribed, and advance diet from clear liquids to solids when prescribed and as tolerated by the client. When it comes to bariatric surgery, we want to teach the client to avoid alcohol, high protein foods, high in sugar and fat. We want to teach them to eat slowly and chew food, progress food types and amounts as prescribed, take nutritional supplements as prescribed, which may include calcium, iron, multivitamin, and B12, and monitor and report signs and symptoms of complications such as dehydration and gastric pain. Then we have a colonoscopy. So this is the lining of the large intestine is examined and biopsies can be performed. Nursing intervention is clear liquid diet day before with a colon cleanse given. There'll be NPO at midnight, and the patient is in a left side lying position with knees to chest while it's being performed. Then we have a colostomy. This nursing interventions are to keep liquid stool from leaking out. This causes skin irritation due to digestive enzymes. We want to change the bag. So this is a bag that's attached on the front of the patient where stool comes out of. They're creating a hole in the stomach into the intestines. We want to change the bag every 4 to 7 days. Increase fluid intake to prevent dehydration, and empty the bag when it's a third full. And then colostomy care. So we want to empty contents of the bag before removing it. Push skin away from the bag, wash the stoma using soap and water, but do not scrub. Inspect for redness, irritation, bleeding, and blisters, and pat dry. Measure the stoma using a measuring guide. With scissors, we cut along the measurement with 1/8 bigger than the stoma. Apply a barrier ring and apply a skin barrier and attach the stoma. All right, so let's talk about a paracentesis and thoracentesis. So these are the removal of fluid from the peritoneal cavity for a paracentesis, or the pleural space for a thoracentesis. It's performed at the bedside. Our nursing interventions are the patient is in an upright position at the edge of the bed with arms on the table for a thoracentesis. Vital signs and weights pre-procedure. Have the patient void if they're getting a paracentesis, and a dry sterile dressing at the puncture site, and measure fluid removal. We have total parenteral nutrition. For our nursing interventions, this is avoid stopping it abruptly as it can lead to hypoglycemia. We want to monitor signs and symptoms of hypoglycemia, such as polyphagia, polydipsia, and polyuria. Then we have something called an ERCP. This is an examination of the hepatobiliary system with an endoscope down the esophagus. Nursing interventions are NPO before the procedure, and post-procedure monitor for return of a gag reflex and for signs of proliferation. And then we have enteral feeding. So this, we're looking for abdominal cramping can occur if the feed is too fast or too cold. Interventions are head of bed 30 to 45 degrees pre and post feed, tube flushes pre and post feed because we don't want it to clot, and assess bowel function. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com.